Hi guys, welcome back to the channel. I'm Justin, your instructor, as you know, and maybe I'm not all of your instructor because some of you are in other classes, but I'm happy that you're here and watching this video on the National Registry Trauma Assessment. So the purpose of this video today is that we're going to go through a National Registry Trauma Assessment on this 10-year-old patient, and we're going to treat him verbatim down the National Registry Trauma Assessment sheet and kind of what to expect. What will the exam look like? We're expecting you to interact with the patient. We're expecting you to use the tools that are on the table, and so we're just going to kind of go through that. I have my friends here with me. This is Jay. Jay, tell them who you are and what you do.
I'm Jay Carter. I'm a paramedic with the neonatal pediatric ground team for MUSC.
Anything else? And this is Mary Beth. Mary Beth, what do you do?
Hi, I'm a nurse slash paramedic. I work for MUSC. I am a pediatric neonatal flight ground fixed wing nurse and background in PICU with children.
So both of these cats have street time. They have hospital time. They have time in the helicopter, time in the back of ambulances, time on fixed wing. So they know what you guys are experiencing, and they're going to help us today kind of bring this to life and make it useful for you. So again, I want to remind you that you have 10 minutes in the National Registry to conduct this exam, acknowledge that it is a trauma patient that is in shock, and emergently transport from the scene. We'll talk about things as we go through the exam, some teaching moments, and then mostly just demonstrating the exam. Mary Beth is going to be our instructor for the exam. She's going to give us our information and answer the questions that I will have as the mock student for you. And Jay will be one of my partners. Remember that you have two partners who are trained at your level, who will do what you ask them to do, but that's all that they'll do. So the whole point of this, guys, is to put yourself in this as if it were real. We want you talking to the patient. We want you using the stuff that you see before you. Depending where you are, there might be moulage, there might be blood, there might be some type of mock simulation stuff that tries to make this as real as possible for you. So we want you to get involved too. If there is a question that you have that you can ask the patient, we want you to ask the patient. If there's a question for the examiner that you could obtain by demonstrating it or obtaining it with touching the patient, that's what we would expect from you. You're going to get a readout that says you will only get credit for the things you request from the examiner or that you physically demonstrate having attempted to obtain in the field, as you would if you were in the back of the ambulance, on the side of the road, in someone's house. So that's what we're expecting of you. You have 10 minutes to declare it a trauma, 10 minutes to get off that scene. And so we're just going to go down the sheet. So as you're watching the video, I hope you have the National Registry Trauma sheet in front of you. You guys have the link to that. We provided on the Moodle classroom. And so when you're looking at the medical assessment sheet or you're looking at the trauma assessment sheet, I hope you're watching that progress as we go down. And give us your feedback and your comments as to anything you think we missed or maybe questions that you might have had as you saw us proceed through the exam. All right, is everybody ready?
Yep.
All right, Jay, ready? All right, let's go. Dispatch, tell us what we got.
You are being dispatched to a 10-year-old male at his father's wood shop. He was helping his father, and he is awake and talking to his father, but there is an explosion with some bleeding.
Okay, so we have an explosion, we have a pediatric patient, this was at a shop. So I'm thinking about that en route to the call. My partner and I were discussing what that might look like, what we might need. And so step one for us as we get on scene is we have on our body substance isolation. We would be wearing gloves, we would be wearing gowns, we would be wearing masks, and eye protection. You agree, Jay?
Yes.
And so if we have that on now, would you say that the scene is safe?
The scene is now safe.
Okay, and because of this type of call, let's get fire en route and let's get ALS backup en route. Is this our only patient as we walk up?
One patient, the father was not involved. He was
Okay.
attending to the patient.
Only one patient, the father was not involved, and this ALS backup is en route to this, fire is en route to this, our mechanism of injury is kind of blast. Is that correct?
Explosion of unknown mechanism.
Okay, and Jay, if you will take C-spine of the patient, because this is an unknown issue, we want to just be conservative until we get more information. So we'll hold manual stabilization of the C-spine, and we'll walk up to the patient. What do we see as we walk up?
He's awake, he's crying, and Dad is with him, trying to calm him, and there is blood noted on the ground around him.
Okay, that's concerning, so let's go and walk up to the patient. He's crying, he's alert, he's awake, is that correct?
Correct.
Let's expose the front of the patient real quick, let him know that we're going to take care of him. We're trying to assess him for emergencies. And what do I see when I expose the patient's clothes?
You
Take it all off.
notice a right penetrating chest wound with some bubbling.
Okay, so I'm going to go ahead and take an occlusive bandage at this time. And you said the right chest, so I'm going to cover that over the right chest, and I would affix it as per the manufacturer's instructions. Or if it required securing, I would tape it on all 3 sides. Is there anything else that I see on the patient?
Yes, left upper thigh is bright red blood spurting from his femur area.
Okay, left upper thigh. I would take some bandaging out of my bag and attempt to cover that. And does that stop the bleeding?
It does not stop.
Okay, so I am going to have my other invisible partner continue holding the pressure onto that wound while I affix a tourniquet. And so are they holding pressure on that wound?
Your invisible partner is holding.
Okay, and it is still bleeding, correct?
Still bleeding.
All right, so let's go ahead and get a tourniquet on this patient. So we have our tourniquet here. We're going to just lift that above the arm, high as possible, tight as possible. And let's go ahead and get that on. And so we just get that on the patient as best we could. And this is going to hurt. I would talk to the patient throughout this process. And I would begin turning this until the bleeding stopped. Does the bleeding stop?
Bleeding has stopped the tourniquet.
Okay, the bleeding has stopped, so I will secure the windlass strap over the tourniquet. And is it in place and the bleeding has remained stopped?
Yes.
Okay, and so any other life threats that we see on the patient?
Some bruises, no burns, abrasions, maybe to his hands and his elbows.
But no other life threats. Okay, Jay, on your count of 3, let's roll the patient to the right and let's expose the back, okay?
Okay.
All right, ready?
1, 2, 3.
All right, rolling the patient. We're going to expose the back of the patient, and what do we see?
It's fine.
Okay.
It's intact.
Since this is the only attempt we have to assess the spine, I'm quickly going to run my fingers down the spine. Do I find any crepitus? Do I find any step-offs? Do I find any deformities, contusions, anything of substance in the back? Okay, and so at this time, we will go ahead and roll the patient back down on your count.
1, 2, 3.
Rolling the patient back down. This is for education purposes only, so we know that that's not going to work on a mannequin. We're going to continue with airway. He's talking to us still.
He is still talking to you?
Okay, and let's check on that rate, rhythm, and quality of breathing. I'm exposed here. I'm looking at the external chest, and I'm feeling it for rate, rhythm, and quality.
Respiratory rate is 28. It is labored with some equal breath sounds.
Okay, so we're going to go ahead and put the patient on oxygen at 15 liters per minute because that rate is a little tachypnic. He is increased in work of breathing, is that correct?
Correct.
So we'll go ahead and put him on a pediatric non-rebreather at 15 liters per minute. I would do that with my partner's help here. And now he's on oxygen. And so now we would like to assess rate, rhythm, and quality of a brachial or radial pulse. And what do we have?
You have about 160 per minute, and it is weak.
That's also signs of shock. Let's look at skin color, temperature, and condition.
He is pale, cool, and clammy.
Okay, also signs of shock. I'm going to reassess the patient for bleeding. Is the bleeding continued to not exist here with that tourniquet on?
It is
Okay,
well
so
controlled.
bleeding is controlled here, and there's no other bleeding, correct?
Just the bubbly chest.
Okay, we'll protect the bubbly chest. Is still bubbling?
No,
It's covered,
Yes.
it's protected, okay. This comes off because we can't really use it, but it is covered, it is protected, and that wound is dressed, and it is no longer bubbling. So we're gonna treat the patient for shock. We have him on oxygen at high flow. We're gonna cover the patient with blankets. I'm gonna check the pelvis real quick because that could be a life threat. And so is the pelvis stable?
pelvis is stable.
Okay, and you already said lung sounds were clear and present?
Yes.
Okay, because that could also be a life threat. So we have our life threats completely managed. We are treating the patient for shock. Because this was a blast, we will go ahead and spine motion restrict the patient, and we will emergently transport. Is that done?
Yes.
Okay, we've concluded the scene size up and the primary. We're entering our secondary exam. And so in the secondary exam, we would like to go ahead and get a sample on the patient. We know the signs and symptoms as they currently exist. Does the patient have any allergies?
No allergies.
Does the patient take any medications?
No
Does-
past medical history.
Does the patient have any last oral intake that we know of? Did they eat breakfast?
Breakfast was the last.
Okay, and how long ago was that?
This
It's
is
lunchtime, okay. And the events leading up to this, you said there was some machinery and a potential explosion of that machinery.
Correct.
There's no burns though on the patient?
No burns noted, it was.
Okay, let's go ahead and get some vital signs. We would affix a blood pressure cuff to the patient's arm. This is an unaffected arm, so we're good to go on this side. I would get a blood pressure on the patient. I would also get an SpO2 on the patient. What are those?
112/60, and
Okay.
your pulse ox is about 95%.
Okay,
You're
things
no rebreather.
seem to be improving. We've treated the patient for shock. We stopped the bleeding. We have the sucking wound covered. So things look like they are improving. I'm going to reassess breathing and circulation. Is that also improving?
Yes.
Okay, good. So that's improving. And we'll get a blood sugar real quick because we should on every emergent patient. And is that normal?
Yes, 60.
And a temperature on the patient. We would check it however we could.
Well, he was cool and clear, so he's about 97.
Okay, we are covered here with blankets. We're going to turn the ambulance temperature way up, keep this patient as warm as possible, addressing the things of stable sugar, temperature, airway, blood pressure, environment. We've done everything I think we can do for the patient. We're going to continue emergently transporting. We've got all of our vital signs. Jay, let's do a head to toe. So I'd ask Jay to inspect the head for decap BTLS.
Okay.
And does he find anything?
Nothing noted.
Okay, and does the patient have anything coming out of their ears, eyes, nose, or throat?
No.
Okay, and is the trachea midline?
Trachea is midline.
Is the patient's pupils pearl? They're equal, round, and reactive. And he said he's still awake and talking to us now, okay, or still rather. And so we're moving into the chest, and I would just listen to those lung sounds again and make sure that they are still equal and bilateral. Is that true?
That is true. Yes.
Okay, and I'm going to reassess since I am here. I'll reassess my dressing. And is it still covered and no longer sucking?
Still intact.
Okay, beautiful. I would move on from the chest into the abdomen. I'm going to palpate all four quadrants, looking for distension, abrasions, bruising, temperature changes, rigidity, rebound tenderness. Is any of that present?
Just a little bit of abrasions, but nothing
Okay,
to be alarmed.
some abrasions. All right, and it's soft.
Yes.
All right, I'm going to reassess that pelvis just to make sure. And is that still stable?
Yes.
And looking at the extremities initially, am I still bleeding controlled?
You're controlled bleeding with your tongue.
Okay, and I'm going to palpate both extremities, starting with this one over here. I probably will stay away from the injury area and just palpate down below it. That feels intact?
Yep.
Do I have a pulse here?
Yes. Or no, not with your tongue.
Thank you. So no pulse there, and I'll palpate this leg, and do I find anything significant?
No.
Okay, and is there a pulse here?
Yes.
Okay, and the patient feels what I'm doing?
Correct.
Okay, and the patient moves their toes and fingers?
Yes.
Did the patient lose consciousness per dad?
Not that he's aware of. He
Okay.
heard it and ran to him.
And I'm going to talk to the patient and kind of just ask him what he remembers of the event. Does he seem to recall?
Yes.
Okay, great. And so I'll continue reassessing the patient every 5 minutes. I'll look at my interventions. I'll look at my bleeding control, our vital signs every 5 minutes. That's our big head to toe. We would give ALS backup or the receiving trauma team a heads up. Again, every 5 minutes. Jay, is there anything you can think of that we didn't do?
No, everything's good. Just remember for JVD, check for JVD.
Yeah, I was going to do that, but
Otherwise,
the collar was in place, but I
Yeah.
I could have checked that JVD in the initial primary, so that is a good thing to remember, especially in a trauma patient, so very good. Anything else?
No.
Secondary wound management, we could kind of clean up bruises and scrapes, but otherwise, I think we would continue reassessing the patient every 5 minutes, and that would conclude our exam.
Sounds
Okay, so that's the trauma exam. I hope you got a lot out of it. I hope you have a lot of questions. So I want to thank Jay and Mary Beth for taking the time to come in here with us and be a part of your learning process. So we appreciate them. Looking for your feedback. I hope this helps you. Let me know. Thanks.